So this is a surgical anatomy. So usually the surgeon's view, when we open the sternum, the next structure seen is the RV, because right ventricle is the anterior most structure. So I keep repeating that the chamber which is most affected in blunt chest injury or direct trauma to the chest is the RV. So what happens during boxing or a contusion injury like a baseball bat or hockey bat, direct injury to the chest, there is sudden cardiac death. What is that? Because of commotio cordis or a VT, ventricular fibrillation, affecting the right ventricular muscle. So right ventricle is the ventricle most prone to trauma. So what is the posterior most structure of the heart? It is left atrium, left atrial appendage. So this is correlated with when transesophageal echo is done, the most visible portion of the heart is the LA and the left atrial appendage. So usually TEE is done to rule out left atrium, left atrial appendage clot, either in atrial fibrillation more than 48 hours to revert to sinus rhythm, or in mitral valve disease before mitral valve intervention. So this is the surgeon's view of a valvular pulmonary stenosis. You can see the right ventricle. So right ventricle usually is a thinner muscular, 3 to 5 millimeter thickness of the muscle. Here it is a thicker right ventricle. So the moment the right ventricle is open, ventriculotomy, you can see the hypertrophy of the subvalve right ventricle, which is a muscle hypertrophy. So it is either a abnormal moderator band or a septoparietal, septomarginal trabeculations. This is the subpulmonary stenosis. Here you can see there is a valvular stenosis also. Here, if the valve is also open, you can see that this is a normal valve which opens like a triangle. Here it is a doming valve. You can see it is trying to open, not inside, not like this, but like this. So it is doming with a central jet. And as expected, this jet is going to hit the LPA and the main pulmonary artery adjoining the LPA or dilated, which we can see here also. That is called a post-stenotic dilatation of the pulmonary artery. So this is the ventriculogram, right ventriculogram in a lateral view. You can see the sternum here. So vertebra will be here. Through the venous axis, through RA and the RV. When the contrast is injected into the RV, you can see the hypertrophied RV, and this is the valve which is doming, and subvalve also there is an obstruction. This is the infundibular obstruction. Subvalve also called as infundibular obstruction, and there is post-stenotic dilatation of the pulmonary artery. This is a classical picture of pulmonary valve, doming pulmonary valve stenosis. So this is the valve. This is a very old journal which is classically described as dysplastic pulmonary valve. You can see it is a very thickened valve. It is almost immobile. It does not have post-stenotic dilatation, or it has associated multiple levels of peripheral pulmonary stenosis. Branch pulmonary, lobar, segmental pulmonary artery stenosis associated with Noonan syndrome. So these are the three comparisons. One is a normal pulmonary valve. We can start from here. When the normal pulmonary valve opens, you can see the orifice is large. When it closes, it is triangular. It is tricuspid. So how it closes like this and opens like this. So like this. This is the infundibulum, which is normal. Normal measurements of the infundibulum and the pulmonary artery up to the bifurcation. Here you can see this both are the doming pulmonary valves. We'll go to systole first. So how it closes, you can see the dome with the central jet, central opening. This is central orifice with the doming valve. So the commissures are fused. Mobility is restricted and there is doming with a central orifice. So when they are closed, commissures are closed. This is in the diastole. And you can see this is a normal caliber. Here it is post-stenotic dilatation, particularly LPA is larger than the RPA. LPA, left pulmonary artery, because of the jet effect is dilated than the RPA. This is a dysplastic pulmonary valve. You can see it is a thicker valve and immobile valve. There is no movement actually. So there is this dysplastic valve. There is hypoplasia everywhere. You can see this is a normal infundibulum. The infundibulum is hypoplastic. The annulus is hypoplastic. There is no post-aortic dilatation. So everything is smaller in dysplasia. Association with Noonan syndrome.